some people will live tweet CSM. All right, we're recording, so let me get focused here. So we're going to do shoulder manual therapy and exercise tonight. I added some manual therapy stuff based on the last talk that we did, and a couple people asking questions about some manual techniques, so I kind of threw those in there. We are going to punt the thoracic stuff to Amy. So, like, obviously, patients with shoulder pain can benefit from thoracic interventions. There's going to be a whole host of things that you'll do to the thoracic spine for patients with different shoulder disorders. But Amy's going to cover the thoracic spine in detail next month, and I'll kind of leave that to her and let the focus of our talk will be more like shoulder specific. But just recognize there's a role for thoracic manipulation. The evidence is a little conflicting, but we do know that it's effective. It's when you compare it to other interventions that sometimes thoracic manipulation isn't superior to other shoulder interventions for people with conditions like subacromial pain syndrome, but it definitely helps. And remember, there's always going to be that patient that's going to respond better than others. So it's just a matter of integrating that into your care. The follow-up to thoracic manipulation, these interventions, typically is going to be some type of active mobility exercise. So just wanted to present that here, that commonly when patients present with shoulder pain, it's an early thoracic manipulation and then an active thoracic mobility drill, kind of like Trent's doing there, where he's rotating his trunk with his hip fixed like that. It's kind of nice just to get his spine and rib cage moving. And then the one on the right there, so that's that kind of traditional quadruped thoracic rotation exercise for mobility. And there's a whole host of other ones. You can, obviously there's a number of things you can do, but just giving a little plug for the post manipulation active movement drill. And then having something to, Trent with the Detroit Pistons, he's doing great. So Trent here is a former student in St. Augustine and now with the Pistons, but active assisted type movements as well. So with the strap, adding that little specific kind of encouraging mobility type of drill to the rib cage on that side as he rotates, or you could do it yourself manually as the patient elevates their arm. That rib cage needs to rotate forward and you need a side bend, right? So when she elevates her arm with right-sided shoulder elevation, there's going to be a concurrent left thoracic side bending. So you can kind of facilitate that with the, with your hand with just a little mobility exercise like that. So when shoulder exercises aren't well tolerated, it tends to give us challenges, right? So you all have had that patient that comes in and you really just can't do that much with their shoulder, the shoulder itself, because they're either, in a post-op status, post-op rotator cuff repair, week 3, week 4, week 5. You can't do that much with the shoulder. Obviously, they're in that protective stage. If it's high irritability case and they just aren't responding well because they're just not, they're just in that hypersensitive kind of phase of the injury, fear, fear avoidance beliefs, and pain catastrophizing certainly is going to cause you some pause when you start to load their shoulder. And so the thoracic interventions are appropriate oftentimes in some of these cases. But I wanted to highlight some other options that you have. What do you do with that very acute patient that you just can't do a whole lot with? And there's quite a bit of evidence out there. The first is contralateral limb training. So just going to the other side and targeting the other limb. So in this case, for example, her left shoulder is the involved shoulder. It's the one that's injured or painful. And so we just simply give her a whole host of shoulder exercises with the right shoulder. There's going to be a fairly decent amount of carryover. That's like a cognitive, it's a neurocognitive process, right? The central effects of exercise are incredible. And so one of the biggest things you need to think about anytime you prescribe exercise to somebody is the central effects. So looking at the endocrine system, looking at the nervous system, looking at the cardiovascular system. But in this case, it's very much a nervous system phenomenon where we get this cross-education. Her left arm will actually get stronger if we do nothing to it whatsoever and only train her right arm, right? And so that Manka meta-analysis that came out at the end of last year was a pretty solid review paper that covers about 30 of the trials on cross-education and contralateral limb training. And you can see the numbers there. It changes based on the upper and lower limbs. The values will change a little bit, and then the different types of exercise. The other important variable is hand dominance. There tends to be a stronger change if the uninvolved limb, the limb that you're not training, is the dominant limb. But, you know, bottom line is they're in a sling. They can't do much at all. Have them do the exercises you know they're going to eventually do with that arm on the other side. And then the other thing is early on, right, you're teaching somebody an exercise for the first time, and they might not even be in that phase where you can't do much with the shoulder. Just start on the other side. Start on the contralateral side. Teach them the exercise on that side, and you get, you know, a little bit crossover effect, and probably reduces some amount of apprehension or anxiety, right? They don't know how the exercise is going to go, how it's going to feel. You can start on the opposite limb. And then the other thing is just the idea of total arm strength. So we talked about grip strength and the role that grip strength has in shoulder pain the other day. But total arm strength is an important phenomenon as well. So just looking at overall elbow movement, looking at biceps, triceps, forearm, wrist movements, and working distal to the injured shoulder can be very, very valuable. So in this case, you've got a loaded biceps kind of exercise where we'll just have her isometrically contract the biceps with a weight in the hand and then externally rotate the shoulder in that position, and then an isometric triceps exercise on this side where, you know, we're keeping the shoulder pretty safe, keeping it stable, but having her contract that triceps as she moves back. Other distal interventions, grip strength, which is so critically important, right? And we talked about that last time, and you know, it's functional. There's a correlation between grip strength and rotator cuff strength. So anything that you want to do to integrate grip strengthening when you're really not able, especially when you're not able to intervene with the shoulder, is nice. A digiflex that you can get very specific with, functional, more like loading up, you know, grip strength, having to carry a stack of plates like that, or loaded carries. There's a very, very valuable aspect of loaded carries in shoulder rehab in general, right, if somebody can tolerate it. But you could start with just simple grip strength in this regard. And then fine motor work too, right, fine motor work. So this is just a simple example where he's digging pennies through a thing of putty, but anything that you could do with marbles and fine motor type of dexterity work, a whole host of things that you can do to work on that. And then the other aspect of it would be proximal, right? So he can't tolerate any cuff loading. I'm not able to do any elevation type work yet. He just doesn't tolerate it. We'll just start at the periscapular musculature. And so a side-lying isometric PNF scapula targeted intervention like that could be really, really nice. He gets some degree of proprioception with that, right? There's a kinesthetic awareness component of it where I can kind of put him in these different scapula positions. He can become aware of where his shoulder is in space, and then we just resist against that to have him try to control it. And you can perturb it, you know, with different speeds and different angles. Adding isometric external rotation to that can be extremely valuable. Now this is a case, obviously, now this patient's able to tolerate a little bit more. We're a little further along, irritability is a little lower, but having him isometrically have to hold a weight in that side and on that shoulder on that side, you're getting great infraspinatus teres minor supraspinatus activation and excellent middle trapezius activation at the same time, right? So side-lying external rotation is actually a great periscapular exercise as well as rotator cuff exercise, high levels of EMG activation of the middle trapezius. And then with that same deal, right, he's perturbing it and providing rhythmic stabilization and isometric contractions at the same time. And then simple reactive isometric. So a little bit better typically than like an isometric where they're going to push against an inanimate object, push against a wall or something. With a reactive isometric, if he can't tolerate traditional isotonic exercises, I can still grade this. I can still, you know, dose load and duration holds and all that stuff. It's a little harder when you push against the wall to dose load, right? Because you don't really know exactly how hard they're pushing unless you have some type of a force gauge. In this case, I can do it based on distance that he stands away from the anchor, TheraBand or resistance band thickness and stuff like that. So that would be for external rotation, and then of course you could, you know, do the same thing for any other direction. I'll typically, primarily with these patients, focus on the periscapular musculature early on, and then the external rotators. All right, so I'll show the manual techniques now. I kind of want tonight focus on just general shoulder concepts, not disorder specific. We covered the different disorders last time, what to look for. What I'll do tonight is just general concepts, and then we'll go to Q&A afterwards and talk about specific cases that you have and stuff like that. So obviously you can apply these shoulder manual techniques to a whole number of conditions. But if the person's stiff, having trouble moving, there's no frank instability, typically going to get in there and feel that shoulder joint and try to get it moving from a manual therapy perspective. So last time I think I had a hard time describing without a video some of these kind of elevation techniques. Traditionally, right, you're starting them typically down low. And I would say, generally speaking, the goal with that technique is really to get them comfortable with my grip, get them to trust me and to be able to relax, right? So guarding around the shoulder is going to be your biggest nemesis when it comes to manual therapy, right? If they're going to guard, the whole point of the manual technique is kind of out the window, and it's going to be very challenging to make progress. So I want them comfortable. I want them to trust me. Part of that is this contact right under here, right? A solid kind of cradled grip contract on the distal humerus, and then my forearm really cradling the rest of their arm and almost pinning their arm around between my arm and my body. And so that can be comfortable. They feel like they're secure and they're not going to guard. And then this hand is providing, this right hand in this case, is providing some degree of stabilization. So that's going to kind of counterforce the scapula. I'm on the neck of the scapula, lateral border of the scapula with the side of my hand there, and then I can pull, provide a distraction and an inferior glide. And then just increase the angle, right? It's all about chipping away at it. So maybe I'm only able to get up to 70, 80 degrees that visit. I'll just go back, I'll oscillate, move that shoulder around, range it again, and then start moving it again like that. What'll happen though is they'll get up kind of high pretty quick, right? Most patients, unless it's severe adhesive capsulitis or just some really restricted mobility, you're going to get them up to 160, 150, 170. And when you get up there, you got to get them in that overhead position. Now I stand at the top of the table, right? So I'm standing on this side of the table. Same deal with this cradling hand, though. I'm still cradling the humerus, still really protecting it and making it comfortable. But then with this manipulating hand here, I can do all sorts of different things. So I can couple those hands together and kind of pull them both to distract a little bit. I could take that stabilizing hand off and have it grab the scapula. Now I'm getting a little bit of that sensation of kind of skin, soft tissue stretching. So those patients, remember, they've been in a sling or that arm's been down by their side for a long, long time. It feels great to get that arm up over the head and stretch out all that soft tissue in the axillary region. And then you can do like there, taking that hand and basically mobbing it, pushing, let me show you this one again, mobbing it and pushing it in an inferior and even anterior direction. Typically coupling motions, typically coupling anterior and inferior, adding a little bit of rotation with it, stretch, stretch, distract, right? Distract, go back to the mob again. Flip that hand around, then start stabilizing the scapula. There I'm checking to see how much range I've got, how much have I improved. Go back to the soft tissue stretch again. All right. So that's a nice little way to work elevation for a period of time and hopefully get a nice big increase in range. Totally cool with stopping at any time if you want me to explain anything a different way, questions, tweaks about this stuff, trouble with hand placement, whatever. Or we can do it at the end also. For rotations, so this would be your traditional external rotation mob. So you get them into ER, same deal, support that humerus really nicely, in this case with the left hand. Take the right hand, and then it's just a posterior glide on the proximal humerus, right? So that's from the that Joe Godge's group. They looked at posterior versus anterior glide in people with adhesive capsulitis. Posterior glide pretty significantly more effective at gaining external rotation range of motion. Patients find this very comfortable. I find it to be a nice prognostic technique, so do it early on in the course of care, maybe even during the eval. see how it feels. Patient benefits from that, and you know you're gonna, obviously have that posterior glide kind of in your wheelhouse. And then for internal rotation, in a lot of ways it's the same technique, but I want to kind of pre-position her into IR, try to kind of hold her in that position and cradle that there, and do that same posterior glide. I know this stuff's not, so in this case, I did the same direction mode for 2 different rotations because am not following the concave convex rule. That's a flawed model. I'm following more the what motion is restricted, what motion is painful, how can I add a manual technique to improve that motion and reduce that pain. More of a manual therapy provides hypoalgesia. The mechanisms of manual therapy are multifaceted, and the capsular bag theory than a concave convex theory. For IR though, a couple of people asked about IR last time. This is actually a better technique. If you're having trouble with IR, you're really gonna like this one a lot for hand behind your back. So a patient comes and says, I cannot put my hand behind my back. I can't reach into my back pocket. I can't tuck my shirt in. So pre-position them into that IR position. They're in prone. And then what you're gonna do is you're gonna take one hand, and this left hand's gonna give a little bit of a inferior glide. Pull that humerus downward a little bit. This other hand then is going to end up pulling, so pre-position, left hand's gonna pull down. This right hand in this case is gonna pull straight out lateral. Give them a nice lateral distraction, lateral stretch, while you're kind of pulling that inferior and in essence pulling them into more IR, right? I'll try to chip away at that, get a little more range, try to get a little, concerned post-op rotator cuff. I'm definitely not doing this. In the rotator cuff population, I'm really cautious about forcing IR. So little side here. Rotator cuff repairs, the worst thing that can happen is you tear it, pretty much, right? I mean, one of the worst things you can happen. So everything that I'm doing in rehab is like, what's the risk-reward ratio? And so worried about that tear. So what they'll say like, I can't quite get my arm back as far as the other one. And I'll say, you know what? I don't really see the value in forcing that. If it's not limiting you functionally, you probably want to just leave the level of mobility that you have right now because you don't want to stress that tendon repair too much more. Now, if it's severely limited and they cannot function, they cannot get that hand behind back, and they're at week 10, 12, 14, 16, so they're through the healing phase of that cuff repair, it's typically going to be a technique that the patient can control to get a little more mobility. So I rarely will with a cuff repair, get in there and force that shoulder the way I'm doing here. This would probably be more appropriate for adhesive capsulitis or just generalized shoulder pain with some stiffness or some other type of injury. They were in a sling and they were stiff, but I'm not worried about a healing cuff tendon because that's definitely a concern. All right, so again, inferior glide there, pulling that lateral, and then you do a couple other things here that I show. So yeah, stabilize the scapula, pull the humerus down, pull them out of that position. People don't like being with their hand behind their back for a long period of time. It'll get achy. Pull them out, oscillate, shake it, put them back in the position again. You can mob it again in that same fashion as earlier, and then you can kind of do that stabilization and pull down. So you'll chip away. You'll be surprised how much IR you can gain to help somebody really get that hand high up behind that back. All right, last manual technique. So love to put people in prone, right? For prone, you've got an automatic position of flexion now with gravity, right? That the patient can kind of comfortably fall into. So the patient's going to comfortably allow that shoulder to fall into flexion. She can control it, which is nice. But this is better than supine, where I have to pick that shoulder up and she has to trust me and not guard, basically, right? So I can let it hang and I can kind of do soft tissue work. I can pick up the lats. I can do one of those soft tissue kind of stretch type techniques. Again, you notice I'm not using the term myofascial manipulation at all. I'm trying to be a little more, you know what I'm saying. But anyway, you can mob the lats, pull on the lats. You can, you just want to get that sensation, that feeling of soft tissue moving through there and stretching through there, so they're more comfortable when they go to elevate. And then this one over here is really nice. You can grab the whole humerus with your hands, all right? Your fingers are wrapping around the anterior aspect of the humerus, and your thumbs are on the back of the humerus. And what you're going to do is basically just work that humerus in an oscillatory fashion. So you're not really stabilizing the scapula right now, but you're just kind of oscillating that humerus back and forth. You can kind of sort of toggle it into an anterior glide. You can pull it and distract it, right? You can mobe it in. That's what I'm doing right there, is mobing it inferiorly. That left hand is pushing the head of the humerus downward in an inferior direction while I'm kind of adding a little bit of a stretch. Go back to the oscillation. People love this. They love the feeling of that shoulder being kind of shaken like that, for lack of a better word, oscillated, and it just lets things kind of relax and free up. So typically not super aggressive from a mechanical and force aspect here. This is more of like a kind of get them loose, get them moving, get them feeling good type of intervention. But prone is really nice for shoulder moves. And then following all of that with some type of patient-controlled active assisted movement. It could be pulleys. Pulleys are great. I don't have anything, there's nothing wrong with that. It could be something as simple as a cane. A cane in supine is really nice, very, very easy technique to do. He can control that, and that oftentimes can become a home, part of the home program for stretching. Obviously, I want him to feel that new range. I want him to feel that, we just gained 20 degrees right after that manual therapy session, and now I really want him to feel and appreciate that new range, become aware in that new range, and sort of push himself a few extra degrees too, right? All right, then what'll happen, a lot of times you guys will see this, right, is where they'll hike that whole shoulder complex. So watch his left. See how his left is just, the whole thing is hike, and that's not a really bad one, but you can see it there. Their scapula will just elevate, and they'll basically use that for one of two reasons. Either supraspinatus deficiency, supraspinatus weakness and deficiency will certainly do it. Somebody with a completely torn supraspinatus, that's like a hallmark sign. They'll hike their shoulder like that to elevate it. Tightness will also do it, though. Like people with adhesive capsulitis or postoperative stiffness, they'll do that as well. So this can be a challenge, and one place to start is definitely put them out of that weight-bearing position, put them in sideline, and have them elevate in this position here. So he's just actively moving that shoulder. Now he's like not really going against gravity. The line of force is actually more against his horizontal abductors now, right? His posterior deltoid, his external rotators, and his periscapular musculature. And so those are all having to work to kind of keep his scapula moving in that direction as he initiates movement into forward elevation. So it's a really nice way to sort of tease out that scapula hike. High volume, very high volume. It's going to be sets of, once he can tolerate it, 40, 50, 60, 100. I might just time him and have him lay there. And when somebody's hiking and we've cleared up most of the other concerns, this is the main home program, right, for somebody that's hiking, as long as it fits where they are in the protocol, post-op healing and all that. All right, another nice thing, if you get somebody, they've got painful flexion, he's having trouble moving into flexion, I'll take advantage of this prone position, and I'll do this one after those prone manual therapy techniques a lot of times too. So I'm going to strengthen him into flexion eventually, but what I'm going to do right now is let him fall into flexion as far as he can comfortably go, and then I'm just going to strengthen him in the opposite direction, right? The central effects of exercise, he's going to have a slight hormonal response, neurological response, hypoalgesic effects of repeated motion like that, right? Central nervous system gets ramped up. So it's a nice way to start loading him, but not in direction that's going to, irritate him or make him worse, and he won't be able to tolerate it. And then from there, I really like, if you can sort of play with what position into flexion are they having trouble with? How far into the range are they having trouble with? Do they have a painful arc, that occurs about 120 to 140? Well, put them at 120 and now start working perturbations in that position. So in this case, she's at 90. Let's say that's where her problem is, right? I can have her kind of push up, punch up against this hand, almost like a serratus punch to try to engage serratus. But then I can really engage any muscle I want just by perturbing in a certain or specific direction, right? So if I want to kind of use her lats to sort of in essence, pull that humerus down a little bit, give her a little more comfort as she elevates. Sometimes contracting the lats, teres major, even subscapularis can give people a little more comfort as they raise up, right? You try to resist those motions isometrically. I can do that with an exercise like this. I can work for fatigue and endurance. I can, do it for a long period of time if I need to, because I'm in a phase where I want to target endurance more than anything else. You have a lot of options. That's a nice early intervention there for elevation. And then doing something she can control too, right? So having her pre-position her shoulder on the wall right before where we're having trouble, and then just working like specific serratus movements in this case, where she's working that scapula, right? Protracting that scapula, rounding that thorax to get nice scapula control. I can, have her that wall as a kind of anchor point. So as she elevates, press into the wall and work different directions like that, right? That'll be a nice prerequisite to before we start doing loaded elevation type of work, is having her slide up the wall for some assistance like that. These serratus wall slides are really nice. You get a lot for your money here, right? So what you end up getting is an engagement of the serratus, which sometimes is neglected. So a lot of times these patients, they'll go to elevate and they just don't have great scapula control, right? You guys see that all the time. And the place to start typically is the serratus. Now, if serratus there's good control, she can round that scapula around the rib cage. She elevates with a nice scapula to humeral ratio. And maybe you don't need to do this, but for the people that are struggling with that scapular dyskinesia, this is a nice one. So she rolls the foam roller up the wall kind of with her forearms, but the emphasis in the cue is I want you to round your rib cage. I want you to round your back. I want to create convexity across the middle of your back, right? I want you to round that back and that rib cage. And so what that does, it also gives you nice thoracic mobility work, right? Where she's using that rib cage and moving that rib cage and sort of expanding her ribs. You can time it with breathing, but you're also at the same time getting an elevation movement that she's working on to kind of hopefully restore pain-free elevation. So one of the challenges with this type of work is you're going to get a lot of potentially pec minor work, pec major work. And so if you have a deficit of the serratus and of the cuff, you'll sometimes see these patients will overcompensate, or they'll just be very pec dominant. If you prereq it with horizontal abduction resistance, it shuts the pecs off. That's what that Park study looked at. They looked at EMG activation of the pecs and serratus and the periscapular musculature with different movements of the shoulders while doing kind of a push-up type movement, push-up plus type movement like that. And when they added resistance band to horizontal abduction, it totally shut off the pecs, pec minor, pec major. So that's a nice little trick you can do to kind of engage the external rotators, turn off the pecs, and then have them do their pressing type work and work the serratus a little bit. Same deal here, right? This is a nice one for external rotator training. So I'm getting the external rotators. I'm also getting the periscapular musculature, middle trapezius, but I can do it in this nice supine position where he's not against gravity. It's not as hard. And then you can also add perturbation. So it's a nice one for endurance. And then you can add elevation to that and slowly chip away at that elevation in a position that's typically not as painful. We talked about shoulder symptom modification procedures last time, and that's kind of one of the tests, right? Where they're going to work resistance against horizontal abduction like that and then elevate. So obviously those patients that benefit from that, you're going to do this type of work as well. And then I think one thing that we'll sometimes do, like we will intervene with the thoracic spine early on. We'll get the mobility going. They're feeling pretty good. They're moving nicely through the thoracic spine. And then we'll start working the shoulder and working them distally. We won't really work trunk rotation as much as we need to, trunk extension from a resistance and loaded standpoint. So working the obliques, working the lumbar and thoracic extensors, even getting up into the cervical spine and working loaded exercise progressions for those regions is important as well. So here's just an example of you're basically adding a trunk rotation to a traditional row. So it's a periscapular exercise with a thoracic rotary loaded exercise as well. All right, and then the external rotators, which really are, that's like you look at the external rotators the way you look at the quads, with knee pain, right? If this muscle is inhibited, if this muscle is not functioning the way you'd expect it to, then it's something that you should intervene with, obviously. There's a number of ways to do it. This perturbation is nice, again, because I want to be able to feel kind of where they're having trouble, and I want to be able to change angles. So I like to integrate stuff like this in addition to traditional dumbbell external rotator training or resistance band training. Something like this gives you a manual therapy kind of angle to it, so you get the hypoalgesic effects, the effects of touch, but you also get that awareness yourself as the clinician of kind of where they're struggling. And then doing the same type of deal, but at the scapula, right? And actually probably do this one for most patients prior to that last one. That last one, his lever was, further out along the forearm, so he's got more challenging exercise in that case. This is not as hard. He's just simply externally rotating in a dynamic fashion with scapular perturbation. But that's kind of nice for that person that clearly has a scapular dyskinesia, and you really want to integrate more scapula-specific work and try to load that scapula in a surprising sort of way like that, rhythmic way. And then working ER into varying angles of elevation is very, very important. So traditionally, this is how you would do it, right? You would add a bolster, or you'd have him just simply elevate his arm higher and higher into the range while training the external rotators. Keeping that shoulder forward in the scapular plane is typically going to be well tolerated, or better tolerated than if you have it back. But this is a nice option as well. So just simple bilateral ER at the same time. You don't even need the towels under the elbows. I don't even really typically do that much anymore. It's just simple. Hold a band and spread it apart. I'm getting middle trapezius activation. I'm getting bilateral external rotators. It's a bilateral shoulder exercise, which is nice. We tend to do a little too much unilateral work with upper extremity cases and not nearly enough bilateral work. This would be a nice bilateral option, pretty easy to do. And the W, you can do this for a couple different reasons. So the W difference is the elbows are low and the hands are high, whereas with the last one it was just traditional kind of nine. He's at neutral elevation and the elbows are at 90. In this one, the hands are high, which causes the inferior angle of the scapula on each side to sort of angle inward, medial. So you get a little bit better of a lower trapezius kind of lat engagement as that scapula pulls in like that. But what I found with this one is some people, they don't tolerate the other one. They'll get a rub or a click. And if I put their hands high and their elbows low, for whatever reason, it kind of brings the scapula back a little bit, which sort of gives them a little more space, maybe subacromial space, and they tolerate it better. So you just kind of play with it. What angle do they seem to tolerate? And then another nice low trap targeted exercise. They're in prone. The elbows are anchored. So the elbows are going to sit on the table. And what I want that shoulder about 120 degrees is just going to simply be lift the hands up while keeping the elbows down. And that's good, Alan. I'm glad you're doing the exercises, following along with the exercise. This could become a lab. You could be sitting there doing all this stuff along with us. That's a good idea. But anyway, the low trap kind of target is just simply lift the hands up, elbows are anchored down. You'll feel that. If you have somebody do that and just palpate their lower traps, as soon as they lift the hands up, you get a low trap contraction. So it's a nice one that's pretty easy to do, kind of forces them into that position. I find the Y, traditional like Ys and Ts are kind of hard to get in the position. It's hard for patients to do that. The lever is so long too. It can be challenging if they're pretty weak. This one is pretty easy. And then a really nice combination here of the Serratus wall slide with the external rotation resistance with the band. So you're getting multiple things here with this one here, where she's going to roll up the wall while those external rotators are going to be on fire, right, from having to hold that band. Yeah, Michael, I think it's a better variation of the Y for a regression, for like an earlier phase. So there's going to be a place for the Y later on. A lot of people are showing that. The nice thing about the Y is that is kind of a really, in some cases, a functional position, right? Getting their
hands up over their head like that and loading the lower traps. If your population is a little older or just more deconditioned, or they don't have that mobility, then it's harder. So this is a good one to try yourself. Now this is high level. Don't get me wrong. Doing that wall slide while your hands are apart, you really, in a perfect world, I would rather her elbows be inside her hands. You know what I mean? So if the problem here is I've got that band's probably not appropriate, and it's hard for her to get those hands out wide. But if you can get your hands outside your elbows and then do it, you will feel a really solid fatigue from your external rotators there. And then this would be it's the same exercise without the wall and without the slide. This one is tricky for me. It's like 50-50. Like I'll flare some people up with this one. I'll get people, they'll feel a click or a pop every time. Look at crepitus when they're doing it. So sometimes dropping the elbows a little bit helps. Sometimes bringing the arms more forward helps. So they get the click and the pop because they're out too close to the coronal plane. And if I bring them in a little bit in front of the scapular plane and then they do it right there, usually they're okay. So another one that you got to monitor it and kind of play with the angles. I can't say that enough with these. Play with the angles. There's no perfect way to do it. There's no such thing as perfect form. It's all about playing with the angles and what that patient can kind of do. Who's the fuel physio? Patrick? That's his name? Oh, that makes sense. Nutrition. So that's his superhero. He rebranded. See, I'm not following it lately. That's good. I'm glad you said that. Scapula elevation now. Now we're just adding components, right? So he's doing that same ER horizontal abduction type movement, and he's just simply elevating into that position. It's a really nice one. So it's kind of funny. Sometimes you'll get patients where you're training them down low, the cuff down low. You're even training them up here, stuff it. But there, it's pretty important to get up into 160, 170 degrees, 180 degrees of elevation and actually work external rotation up in that position. So one thing that he's not doing that you could do that's a little better is instead of wrapping the loop around your hands like that, just, I wish I had a loop. Hold on a second. I'm going to use a roll of stamps to demonstrate. So instead of doing that, just have your band just like free, kind of hanging. It's just a strip, a band like that, and hold it with the thumbs up. The thumbs are up, and the band is across the top of your hand. And then in that position, get up overhead, get all the way up. Sorry, get all the way up overhead, and then work ER up like that. So he can elevate, right? He can elevate and then work external rotation and try to horizontally abduct up in that position. So you're basically working external rotation in an overhead position. I've used this to help. Yeah, that's a good point, Sarah. It's like you get them up there and you start loading them, and then all of a sudden their range improves because they have more control. Yep. Yes, we still use stamps. Not everything is done on the internet, Alan. All right, and then resistance this way is kind of nice. So the problem with that other one is it's not really load, right? You could do that with dumbbells in his hand, but he's not working loaded elevation. You can create loaded elevation just by looping the band around the back and under the axilla. And so it's wrapped around the back under the axilla, and then she just elevates, same type of a wall slide motion, rounding that thoracic spine, rounding those scapula around the rib cage, and doing it against resistance. So you got a number of different wall slide interventions that you can progress all the way through. D1 flexion is another good kind of scapula control elevation type movement, primarily because you're getting the serratus to have to pull that scapula all the way around the rib cage. So it's a nice kind of force the serratus to engage, force the scapula to elevate, bringing that humerus up like that. So that can be another option.
And then just general, getting that thoracic spine extended, getting his scapula back, retracted, posterior tilted, and then having him elevate in that position is really nice. So this would be, instead of your traditional doorway stretch, right? Stand in the doorway and just repeatedly elevate. It's like a neuro-re-ed type of exercise. Do this yourself for 3 minutes straight. Actually time it and do it for 3 minutes straight. You come out of that and your extension is better. You feel like your chest opens up. You can engage your periscapular musculature a little bit. So I actually use this as a warm-up, a lot of times warm-up. So if the patient comes in and you manip the thoracic spine, you do some thoracic mobility work, then have them stand up in the doorway like that, elevate the arms in that they're sort of forced back. So he's standing in the doorway and his arms are forced back, which forces his trunk up into extension. And then, and then do your shoulder progressions after that. Supine snow angels. Yeah, same deal. That's nice. And that supine snow angel is probably actually a better initial exercise. Then get them up and do this after. But that's a good option. Good comment. This would then be another progression. So now what you're doing is, instead of putting him in the doorway, his back is up against the wall. So when his back is up against the wall, he has to actively engage the periscapular musculature to pull those elbows back and then elevate in that position. So it's just he's using more muscular recruitment in that case to get his arms up over his head, as opposed to forcing him that way with the doorway stretch. So that's a nice progression as well. Try to do the doorway one first, then do this one, right? And if you do each of those for a couple of minutes, it's really a nice way to get started on the shoulder program. It's a good pre-gym warm-up too on a shoulder day, because you really get you to understand where your T-spine is and open you up a little bit. All right. So pressing movements, we alluded to this a little bit earlier, but at some point we're going to want to integrate loaded elevations and pressing movements, right? So that they can function with that arm and pick stuff up and lift stuff overhead. So sustained holds sometimes are kind of nice with a lower load. They can't tolerate a heavier load. I'll have them do a low load, press it up. In this case, she's doing more of kind of like a tricep elbow emphasized type movement, but you can have her elevate that shoulder, that arm up overhead, and then use same deal. Perturb it in whatever position you believe they're having trouble in. You can do sustained holds. You can do rhythmic stabilization back and forth like that. And then closed chain, integrating closed chain work. So we've got to integrate closed kinetic chain exercises along the way. It's very, very important. We get the bilateral effects of exercise. We get that thoracic mobility, right, which is so important. So she's going to round her scapula with those, just like we want to engage the serratus. She's having to load that arm in a closed chain manner, forces her elbow into extension or wrist into extension. You can play with a lot of different positions with that too, right? Staggering the hands, having the hands wide, having them narrow, and then integrating gripping movements with those shoulder movements too. So earlier on, we started with the grip stuff. I wouldn't leave it at that. I think when you get them progressed enough that you can really load the shoulder, bring them up overhead, and then have something in their hand that they have to grip or squeeze, a functional task that they have to do, you're kind of integrating everything at that point. And then this is just like putting her in different positions. Certain positions painful. I put her right before that painful position and have her grip and kind of dose that with a fairly high rep set scheme, right, to work endurance, grip endurance in that elevated position. This is the heavy load eccentric training exercise that we did. I talked about this in a PT on Ice a couple of weeks ago, and the idea here is overload that tendon tissue, overload that muscle tissue, try to stimulate growth and strength gains in people with chronic rotator cuff related shoulder pain that aren't responding to your other interventions. So at some point, you just say, I'm going to load them up and stress their nervous system with this level of resistance and see how they respond and see if they respond favorably. You'd be surprised how many people respond favorably. I historically was always afraid of flaring people up, giving them too much. But I think actually the mistake I probably made and do make today still more frequently is underdosing, right? A simple, basic external rotation resistance exercise like that needs to be loaded up a little more. So what makes it eccentric is that's a thick silver color resistance band. He can't really concentrically move that resistance for 15 repetitions on his own. He requires assistance from the other arm to get it out there. And then I really want to slow release back in. So typically we're doing this as a 2-second out, 2-second iso hold at end range, and then 4-second slow back in, right? So it should be slow and controlled, obviously. And then other overhead progressions. So the shrug is kind of nice. We talked about that earlier, getting their arm up over their head and working rotations, but just having them have to kind of punch towards the ceiling and work that upper trapezius in that overhead position is nice. It's very functional. You need that last 10 degrees, 20 degrees, right? To just really push that weight up overhead, lifting something up, putting it up on a shelf. That's a lot of upper trap work when you get up in that position. And so that's what that exercise is for. You could do that bilaterally with a barbell. You can do it with a dumbbell. You can even anchor a band on the ground, have them step on it, and push up overhead. Yeah, eccentrics for stiff shoulders. That's a good play too. Sometimes people don't respond to these manual techniques, and we just start loading them up, and you'd be surprised how much the range will clear up and improve. The whole key to the whole thing is just trying to figure out what is giving me significant within session change and what is not working that I need to move past. I mean, I think when I have gotten bad outcomes, it's because I've been trying to do the same thing for too long and I haven't moved past and I haven't found what unique intervention works well for that particular person. Hand walks, another nice kind of closed kinetic chain alternative. The lower you can do this with a high-low table, so the lower you put the table down, the more load's going to go through the shoulder, the harder it's going to be. The higher up the table is, the closer their feet are to the table, the easier it's going to be, the less weight that's going to go through it. So you can have them step back and you can lower the table a little bit. But the walking movement is kind of nice just to get that, compression through the joint. You can feel that load through the shoulder and then have them do different movements. And then in the full push-up position, again, back to that weight-bearing concept, adding perturbation. She has to control. This is a great endurance exercise. She has to control with her cuff or serratus or deltoid or triceps, grip strength. It's just such an all-around exercise. It's going to improve her upper body, upper quarter function. Core control, abs. I mean, you can get a lot out of that. Having to elevate the body weight is important too. This is one thing. I think you want to do something where they have to pick up their body weight, elevate their body weight in that closed chain shoulder type exercises. So the step ups, shoulder step ups are one of the better options you have, where you just put a step in the middle and they literally just kind of step up and down over it, like on either side like that. It can be quite nice. I can do that for speed. I can do it for time. There's a lot of outcome measures that you can use to objectively see how they're doing with this. And then ladder steps, side steps with the ladder. So pretty simple stuff, right? Just having them walk. You could do bear crawls. I mean, the sky's the limit when you look at closed kinetic chain shoulder exercises for the higher level people. You can get very, very creative. All right, so that is it. I would love to go back and revisit any of that. Again, take your questions, talk about specific cases, those manual techniques. If you're listening to this later on, recording, and you want to practice those techniques and you want to just shoot me like a video so you can get feedback on it, look at your hand placement. You have specific questions about any of them, you can always DM me or email me, or we can connect via phone, telephone as well. So anybody got anything?
I have a question.
Yes, ma'am.
How much do you typically wait? How much range of motion do you typically wait for overhead before you start doing a lot of loading?
Just depends on so many factors. Because I think like Michael's point, or somebody made a point earlier on, was you know, the shoulder is sometimes the stiff shoulders respond well to these overhead exercises. Like the normal course of rehab for it, right? They're stiff. They require some degree of manual therapy, passive stretching, active movement, fairly benign type of elevation movements. They respond well to all that. They're improving, and then you load them, right? And I think, but to be very direct answer to the question, like, let's say they're stuck at 120 and they're responding, and you've gotten them from 90 to 120 over the past 2 weeks, but they're stuck at 120 right now, I'd still be loading them at 90, 100, 110, part of the case, if the irritability is such that they can tolerate it and the movements are well tolerated. So I don't think like there's a specific time that you like say, I'm not going to load them overhead because they don't have X, Y, and Z. Now, at the same time, what if they get overhead and it looks horrific, right? Scapula's all over the place. They're hiking. They have pain. You know, you look at their spine is side bending a bunch. That I might not be totally in love with that either, right? I might want to say, all right, let's take a step back. Let's work your scapular mobility, thoracic mobility, shoulder work, some light isometric work, a light isotonic work, and then get it going. So, well, I feel like that's not the best answer. Maybe do you have like a specific case or scenario that like is challenging or that is that applies?
No, I don't think so. I think that really does answer it somewhat. I think I've just been lately, out of my own personal experience with overhead pressing, I've been playing around with it a lot with patients. And I've had some, and I guess I'm answering my own question that I should probably be loading people earlier, but I've definitely had a lot of people who are like, oh, they do that kind of like almost pain-seeking thing where they like move their arm around and are trying to find, oh no, it just hurts if I'm kind of right up there. And so for them, I've just started loading overhead. And it's because I'm just like, stop, just press, do something. But I was just curious. I've had all sorts of the spectrum from acute post-op to athletes lately.
That makes me kind of also think of like, what did they get before? Like I'll get a CrossFit person who's been doing nothing but the kind of play with the overhead movements, play with overhead loading, and has never done any like isolated cuff work. You know what I mean? So to me, that person, I'm like, all right, well, let me change gears a little bit. Let me see if I can get some more like kind of dynamic control of the shoulder joint and some of these smaller muscles, and then progress them. Or get the opposite. I get the person that's just been given like yellow TheraBand for the past 6 months and has done nothing but cuff specific work or kind of low level, what we would all think is low level type work. And for that person, I'm like, well, we haven't really tried overhead loading yet. Like let's go. But yeah, the impingement case where you just got that kind of little tweak, kind of, oh, get up overhead, and I just got a little tweak up in that position. To me, that's somebody that I really want to mob their shoulder to see if I can get a little more range out of it, a little more pain-free movement out of it, or do some specific little kind of like control exercises like the one I tried to show with the stamps, where you're up overhead and you're working rotations, isometric control, you know what I mean? Like kind of building endurance and strength in that position right before the pain.
Totally. Thank you.
Yes, ma'am. Yeah, Alan, good example. The overhead athlete, then you put a 3-pound dumbbell and they fatigue outside lying ER. I was working out with a friend the other day, actually. He's been just like heavy kind of Olympic lifting for the past couple of years, and I was like, let's finish this workout with isolated knee extension machine, you know? He was like, could really barely even do a handful of plates. So there is something to the isolated work for sure. Supersets, I love supersets, drop sets. Absolutely love it, Aaron. That is, I think I've done a couple PT on ices on this, but that maybe we can link up for you if you go in and look at that. I did one where I showed a couple like drop sets for the shoulder, but absolutely love, love, love supersets and drop sets, and mechanical drop sets where I'm keeping the weight constant, but doing a very challenging movement first and dropping to easier and easier movements, or just a straight up loaded drop set where you grab a 10-pound dumbbell and knock that out for 20 reps, and then a 15 and then a 10, that type of stuff. Yeah, drop sets for hypertrophy, we did cover it in that one, but yes, can't say that enough, how much supersets and drop sets and pushing people to create physiological change, pushing people to failure when you can get away with it because their tissue irritability is not that bad and they are in a position where they can kind of tolerate it, is huge. Yeah, thanks for that comment. What else? Other questions, cases? Higher than 10-pound weights, yes, that is kettlebells are kind of nice. You can get just a kettlebell that's a little heavier. Your manual resistance is pretty nice. That sky's the limit there, right? Yeah, work on them for sure. Or just go like buy them yourself and be like, look, I am invested in this clinic. I went to the pawn shop and I got us a 20-pound dumbbell. Bring my own. Yeah, Joel, bringing your own kettlebells to the clinic. Yeah, that's a good call. Loaded carries. That's the thing with those loaded. Play with loaded carries a little bit too with these patients. I didn't show any other than that one grip strength one, but yeah, bottom up loaded carry, farmers carry. I mean, there's waders carries. You can sky's the limit. It's really a lot you can do with that. Very functional. Slosh beams. So is that the bar that has the weighted balls inside it that will like swing to one side and make the bite? Oh, yes, same principle, PVC pipe with water. I have not. I've played with those, but I've never used one with a patient. But I see a lot of merit in that. That is a neat concept. Thanks, Alan, for posting that link. So we'll definitely check that out. But yeah, like any type of altering perturbation type of mechanism, body blades, in this case, the slosh beam, you could do so much with that. They make a barbell. I was at an NSCA conference. They make a barbell that is hollow on the inside and filled with little like balls, little lead balls. And so, but it's not completely full. It's only like half full. So as soon as you will like lose one side just a little bit, all the weight would swing to that side, and you would like, you'd be trying to fight from dumping the weight. So that's kind of a neat little thing, that advanced barbell type work. How to build a slosh pipe. That's great. Yeah, definitely. Nice perturbation. Ripstick. Anybody use ripsticks ever in the clinic? Ripstick is just a pole with a resistance band on one end, basically. But you can do a lot with that too, from rotary resistance work for the shoulders, working the obliques, and all sorts of different movements. One that I haven't heard of anybody doing. What about the clubs? Anybody use the clubs? The weighted clubs. Probably some application for that. Yeah, Indian clubs. Yeah. All right, cool. Well, any other buy work? Yeah, nice. What's a steel mace? Like with the chain, the ball and chain?
It's like a progression of the Indian club. All the weight is right at the very end. It's like a very thin stick, and all the weight is focused on the very end.
Think of the mace with the spikes, the weighted ball with the spikes on the end. It's got a chain.
I think you're thinking ball and chain, kind of medieval.
No, it's definitely it's called a mace, dude. Google it. It's like a Braveheart style weapon. I'm pretty sure it's called mace.
I don't know. You still have stamps. You can't be trusted with technology.
Chronically stiff shoulders, patients with comorbidities like metabolic syndrome, addressing the metabolic comorbidities. Oh, yeah, hell yeah. If not more important than mechanic. Yeah, hell yeah. I mean, that's the whole, like, treat the whole person. They absolutely, yeah, the whole everything from the APHPT crew. Does their shoulder mobility matter all that much when they, are essentially killing themselves with this, with these different diseases and disorders? So yeah, that person needs holistic care and less so shoulder modes. Then again, I mean, you can concurrently, obviously treat the shoulder, and you can change in glucose control, impact the mobility. Yeah, when you read the adhesive capsulitis literature, it is amazing to see the endocrine and thyroid and metabolic relationships to that disease. And so there's definitely something there with the fibrosis that occurs within the joint capsular tissue and these systemic disorders. But thyroid disease is correlated with adhesive capsulitis. Diabetes is correlated with adhesive capsulitis. And so you got to kind of think about that in the post-op population as well. Like, so yeah, they're in a sling for 8 weeks, and yes, that's creating stiffness, but what's going on in their overall health and system that's also contributing to it? So great point to bring up. Yeah, that's a good question. Why does adhesive capsule attack the glenohumeral joint most? Yeah, I have no idea whatsoever. I find a lot of these autoimmune and idiopathic onset disorders. It's very interesting. I mean, it's like, why does RA attack the MCP joints, so severely? I mean, it attacks other joints as well, but why are the MCP joints so involved? And yeah, very interesting. Cool. Well, anything else you guys have, you know where to get me. Certainly post up on Facebook. You can DM me. Happy to have a phone conversation with anybody about cases. If you're struggling with a case in the clinic, I want to just chat through a shoulder case. Sometimes if I can hear a lot of detail about like kind of what you're doing, how the patient's presenting and all that, I can give a little better recommendations. I could shoot you resources, research articles, stuff like that as well. So happy to help. Anything you guys need, don't hesitate.
Cool. I will stop the recording and then get this up on the Vice website in a few minutes.
Awesome. Thanks, Joel. Thanks, guys. Thanks, everybody. Alan, I'll shoot you the PowerPoint right now.
Okay, sounds good.
Thanks, guys.